Right. Okay. Well, thanks for joining everybody for the June spinal cord protection. We're not going to call it immobilization anymore. Protection guidelines review. We've got three presenters today. We're going to go over the guidelines by the WMS, and then we've got two journal articles, and then we can kind of talk amongst ourselves and experiences after that. But our first presenter is Michael Sullivan. So whenever you're ready, take it away.
All right, sounds great. Thank you, Justin. Hello, everybody. My name is Michael Sullivan. People call me Sully. I am a M4 now at University of Maryland. Still getting used to saying that. I'm excited to talk about these spinal cord guidelines with you. They have changed quite a bit since kind of my time of what the Boy Scouts taught me back in the day, getting the first aid merit badge and things like that. So I'm excited to, a lot of changes. It was pretty fun to go through and excited to talk about it with everybody. I'll be trying to keep an eye on the chat while doing the presentation, but if anything comes up, if you have any questions, feel free to unmute and stop me and I'll be happy to answer them the best I can. So going to follow the structure of the guideline paper pretty closely. So we'll just be going through kind of piece by piece, but it started out by talking about what the wilderness medicine guidelines have been like in years past. And the best practice has changed quite a bit in the last few years. And they've actually begun to kind of realize that there's not much evidence supporting some of these ideas about using rigid collars and backboards and things like that. And a lot of those decisions might have been more influenced by things like medical legal concerns and untested theory. So the authors behind these guidelines came together and we're hoping to clarify that and see if we can't make things a little bit more clear and a little bit more safe. And they begin by talking about it's kind of a big deal to decide to immobilize someone's spine when you're in a wilderness setting. You can add a lot of difficulty to getting somebody out. So somebody who you thought would just be able to walk all of a sudden needs to be carried. That creates potentially more time for the patient to get to definitive care, more danger for the rescuers, and all of the above. So the following guidelines that we're going to talk about here today are the 2019 update to the wilderness medicine guidelines that were first established, I think, back in 2011. And one of the main things that they focus on is a shift from technique-based principles or mechanism-based principles, so thinking about exactly what you're going to do, to more goal-based principles of what is your overall goal for spinal cord protection, how are you going to achieve it, and not necessarily leaning into just an XYZ algorithm that you slap a cervical collar on everybody and then call it a day. So just a little bit about how these guidelines actually came together and were made. The team had a variety of different specialties behind this group. There were 2 orthopedic surgeons, 2 academic paramedics, 1 military, 1 civilian, 2 emergency/EMS physicians, and a family practitioner with sports med background. And studies that were used were randomized controlled trials, observational studies, and case series. There weren't an abundance of those randomized controlled trials, which is something we'll get into. Any review articles that weren't meta-analyses or abstract-only reports were not included, and any place where the literature couldn't come up with an answer or a recommendation, they used their pooled experience, any case studies they could find, and topical review publications at that point. So a little bit about the prevalence of spinal cord injury. 54 million cases of spinal cord injury a year in the US. It's about 3% of trauma admissions. Of this group, 2 to 10% will have a neurological deterioration after their initial testing. So some of the things that can contribute to this, you could be thinking about attempting to intubate somebody with an unstable spine and causing further damage, or using too much traction. If out of the acute period, you might be looking at a sustained hypotension, and once you get even later than that, arterial injury could cause further damage. And notably, we have no studies that link any particular type of pre-hospital care or method of immobilization directly to an increase in neurologic degeneration. So it's not to say that it doesn't happen, but we don't have anything in the literature that has a super clear opinion on this. So Over the years, there's actually been a trend that people who arrive to the ED with neurologic lesions, complete neurologic lesions, these patients have been decreasing. So in the 70s, there was 55% of patients referred to spinal cord injury centers had complete neuro lesions. And by the time you get to the 80s, it's dropping. Some people like to think it might have been the initiation of emergency medical services and a more streamlined triage and pre-hospital care process. But people are thinking that maybe it has to do more with better automobile safety, where a lot of these accidents tend to happen. And you can see that just by knowing in the late 90s, early 2000s, about half of the cervical spine injury from automobiles were from unrestrained passengers. So the authors of these guidelines reviewed the case reports of neurodegeneration after spinal cord injury in the setting of inadequate immobilization. And even though there's been some studies out there that people have pointed to saying, look at this case where somebody shows up with a spinal cord injury and it got worse because they were inadequately immobilized, the authors, it was their opinion that almost all of these actually were more likely a late or missed diagnoses or a degeneration that happened once they actually were brought to definitive treatment. And they start off right out the gate mentioning that spinal cord immobilization is not a risk-free procedure. It certainly feels like, why wouldn't you put the cervical collar on? Just, be safe. How bad could it be? But turns out that there's a couple different things that can happen with this. For one, they're just really, really uncomfortable. If patients do not like them, they can actually end up having a harder time breathing, and increasing the danger of the rescue if you're going to be pulling somebody out, needing to carry, needing to bring in more rescuers, putting more people in a potentially harmful situation. And there used to be an old push to categorize patients, is their spine stable? Is it unstable with potential injury? Is it unstable without apparent deficit? Is it unstable with deficit? But some of those categories aren't seen as useful anymore, so they don't get too much into categorizing your patients as they show up. And there's all this talk about clearing the spine, generally regarded as more of a vernacular than an academic saying. Some organizations have been saying to reserve it for determining whether or not you can evacuate somebody by carry or whether they can get up and walk out of the wilderness setting. But they've also been challenging this concept of spinal cord immobilization. And there's been this push in recent years that instead of a complete immobilization, the goal should rather be spinal motion restriction. So rather than making sure somebody's not moving at all, making sure their spine is supported in a relatively anatomic position, maybe with a little bit of traction, those seem to be like the more safe, more recommended ways to do it now. But it's important also to note that that has not necessarily been proven to be more protective than complete immobilization. We just know that complete immobilization has a handful of problems, which I will continue to get into over the course of the talk. So as I kind of touched on this on the first slide, but they've recommended to stop thinking about the mechanism of exactly how you're going to immobilize the spine and begin thinking about it as more of a goal of spinal cord protection. And I loved this quote from the paper because I feel like you rarely get this kind of honesty in academic medical papers. But this quote here, the basic gist of this argument is that we know our goal is to protect the spinal cord, but we do not have good evidence to support how to do that. And this comes before all the recommendations that you're about to read here. So there's something to keep in mind, that this is what we believe the best way to do it is right now. Hopefully there's more information coming out soon and we can have a better idea of whether these interventions are exactly the right ones, but we will get into all of that as we go on. So just FYI. And another, the last kind of thing they mentioned is that these recommendations were constructed with a focus on wilderness, but some of these conclusions aren't necessarily confined to the wilderness alone. So they encourage the readers to think about where the overlap of this can come into hospital care, and other scenarios as well. So that is kind of the groundwork of what they wanted to tell us before we actually get in to going through some of these recommendations. So any questions about that, anybody? All right, sounds like a plan. Then we will go ahead and get into it. So the slides are kind of arranged by the title is typically the question at the top, and the recommendations are always bolded with the supplementary information about how they came to these recommendations is around it in a couple various ways. But we'll go through them. So the first question that they addressed is, what is the preferred position for somebody who does have an injured or suspected injury to the spine? Now, the current recommendation is that neutral alignment should be restored and maintained using non-rigid tools during extrication unless such a maneuver is met with resistance, pain, or a worsening neurodeficit. And there's a important underlying thing here going on saying non-rigid tools. So these rigid cervical collars are beginning to fall out of favor in the wilderness setting, and we will get more and more into that as the presentation goes on. But at the moment, we have no studies that have specifically evaluated this question, but the patient care experience of the panel, traction studies, operative reduction techniques, everything kind of points to suggest that neutral alignment is best. And I think most people would kind of have the intuitive sense that that feels like the right thing to do. And at this moment in time, we have no evidence to say it is not the right thing to do. So keeping the spine in neutral anatomic position is good, as long as any maneuvers to get people out of a tricky situation are not met with any pain or a worsening neurodeficit. And my presentation wants to, oh, there you go. Good. Sorry, a little technical difficulty, but moving on, going past that to the next step, for actually extricating somebody from a scenario with a possible C-spine injury, there's been studies with 6-camera motion capture systems that reveal that when individuals are exiting a car on their own, it actually results in less movement of the cervical spine than pretty much any other technique that has been brought to bear previously. So they showed even when you have 6 trained EMS professionals assisting somebody trying to get out of, I believe in this particular study, they were looking mainly at automobile accidents. More often than not, if you have an alert and reliable patient who can look at you and say, yeah, I can crawl out of here and I can keep my head as still as possible, you should let them do it. And that's going to end up objectively having less movement than any other of the techniques that we have brought into the wilderness setting before. And notably, one important finding of this study was that backboards tend to actually result in more movement, especially with an increasing weight of the patient, which probably makes objective sense. If you think about it, it becomes harder to keep a backboard stable as you're pulling somebody out of a car. But the culmination of these studies is the panel recommends that if somebody is awake, alert, and reliable, they should leave the situation of their own volition, whether that be a car accident, as the example I brought up here, or any wilderness accident. If somebody can stand up and get themselves out, they should be allowed to do that without keeping them still for the sake of a potential C-spine injury and being worried about any worsening neurodeficit. And the effort should be made to reduce passive motion without the goal of complete immobilization, and there is no required role for a commercial or improvised cervical collar. So it is a little bit of a change and something to keep in mind, that people can get up and walk out. If they can get up and walk out, let them do it. Then moving on, they were talking about some of the other aspects of moving patients with a real or potential C-spine injury. They talk a little bit about traction here. So this is standard in hospital for treating patient or moving patients with spinal trauma. It's a way to help keep anatomic position and prevents any distortion. And for anybody who is maybe earlier in training and hasn't gotten too much on traction, I know we don't talk about it too much explicitly in the preclinical years, but traction is essentially keeping that pressure on the neck to keep the spine in an anatomic position, and as well as giving it a little bit of pressure to kind of stretch it out. And here are two examples here in the pictures to give you a sense of what that looks like. And in the monitored hospital setting, sometimes this traction can be a lot of weight. If you have the right patient and they need a lot, it can get up to 68 kilos have been used for the reduction of unstable spines. But in the unmonitored setting, you're not going to want anything close to that. And the thought process behind that is if you have a compromised bony or ligamentous section of your spine and you are yanking as hard as you can on somebody's head and trying to pull their head off, their spinal cord and their ligaments and bones aren't there to protect that anymore. And instead, you're just pulling right on the spinal cord, which is generally regarded as bad. So you just keep that in mind. Then there's also, they talked a little bit about when thinking about moving these patients, how to actually get them onto a backboard so you can get them onto a stretcher. And there's a few different techniques that have been described. There is the lift and slide, and let me see if I can successfully pull up these videos without creating too big of a mess. Can somebody unmute or give me a thumbs up if they can see that? Is anybody able to see the video?
Nothing yet.
Nothing yet? Let me see here. Let me see. I'm going to do a quick reshare here just to make sure. All right. How's that?
That's good.
Good.
Yep. So this is the lift and slide method of getting somebody onto a backboard, which here's a quick little clip, nothing too fancy, but you have a couple people over the patient, picking them up. You'll notice somebody at the top of the head, making sure to provide traction while they move the patient. And we'll get a little bit into the methods of providing traction in a second. So that is one. And then I'm going to pull up the other. So that was the lift and slide method. And then you also have the log rolling method. Log rolling might be a little bit more familiar to those who spend time in the hospital. This is how we move patients quite often. Find the video here. Sorry, just a second. No, I brought it up. I was going to try to describe these with words, but I didn't think I was going to do a very good job. So I wanted to. Oh, here it is. All right, so that method before was lift and slide, and then log rolling is right here. So pulling the patient to the side, pulling the board out, and then moving the patient from that point on. So those are the two methods, and they have evaluated the two methods against each other to see which is safer and more effective. And let me just get everything set up here again. They've evaluated the two methods, and turns out that the lift and slide is a safer method, superior stabilization of the entire spine compared to the log roll. So if you're in a position where you're going to need to get a patient with potential C-spine injury onto a backboard and you have the manpower, lift and slide is what would be recommended. Then when you have a patient who you do need to get onto this backboard, you also need to provide that traction I was talking about at the head. And there's two different ways that this has been provided in the past, or two different methods that they looked at for these guidelines. And that is the head squeeze method, which makes a lot of intuitive sense to just hearing it. You've got your hand underneath the patient's head, using your ulnar fingers to grab the mastoid process, second and third finger to apply jaw thrust if needed. And there's also something called the trap squeeze maneuver, which involves grabbing the traps with your thumbs anterior, using your forearms to stabilize the patient's head, and keeping the patient's spine still in an anatomic position that way. And in this case, the trap squeeze maneuver was shown to be superior in a 2011 study out of the Clinical Journal of Sports Medicine, particularly if your patient is agitated, which I found was interesting. Does make a lot of sense though. If you've got your hands on your traps and you got your forearms, you can give a little bit more support in these situations and would be able to help support a patient's spine if they were agitated. So this is the head squeeze maneuver, probably a little bit more commonly seen or maybe a little bit more intuitive, but this is not what they currently recommend. They currently are recommending the trap squeeze maneuver, where your hands on the traps, using your forearms to keep the head in anatomic position. And I did like that this picture on the left here demonstrates that you can get around helmets and things of that nature using the trap squeeze perhaps a little bit easier than you could with the head hold. So they're also talked about this idea of lateral positioning. It is something that is done in the hospital where people with spinal injuries can be kept in the lateral decubitus position. They didn't find any evidence against this. They found one cadaveric study that showed there might have been some additional movement actually in the medial to lateral plane when comparing log roll transfer to a lateral positioning of a patient. And this might be of particular interest in vulnerable airways. It was something they wanted to bring up and mentioned in the guidelines. But overall, from all that information, the recommendation is concised down to that the lift and slide method with a trap squeeze is the preferred method of getting somebody onto or moving a patient when you've decided that motion restriction is indeed desired. And if you have concern for airway compromise, lateral position may be considered. You're going to want to provide light to moderate traction when using these maneuvers, nothing heroic or wildly strong. So the next recommendation that they get into is on the effectiveness of spinal immobilization in reducing neurologic sequelae. So this is the question: are we really preventing people from when they have these spinal injuries ending up slipping their bones and causing further injury, and maybe they were okay when they were in the wilderness and got injured, but now we've caused them to no longer be able to walk because of our negligence by not putting on a cervical collar? This is the question they want to address. A Cochrane review found 0 randomized control trials to address this question. There is currently uncertain benefit versus harm in the literature, though the authors brought up a couple different studies here. They mentioned that there was a review that compared a US hospital in New Mexico versus a Malaysian hospital. And of 120 patients in Malaysia that were transported without spinal immobilization versus 334 patients in the US transported with, you actually saw less neurologic disability for the patients who were not immobilized in Malaysia. Certainly there are probably other factors at play in that study. I didn't get a chance to read it, but just interesting, something that was brought up in the guidelines. And it has resulted in the recommendation that spinal cord protection should be the goal as opposed to spinal cord immobilization. And current evidence suggests that spinal motion restriction is actually the safest and most effective means of doing that. And so the rest of the recommendations get into a little bit of the how-to for that question. So the current gold standard is the cervical collar, though we have little evidence to indicate any effectiveness with it. And if you're assuming that anatomic position is best for an injured spine, it's important to note that more than or around 80% of adults require some sort of padding or modification to a C collar to make sure it's actually neutral position relative to the torso. Another assumption is that these cervical spine collars actually restrict motion, and some studies have brought this into question. Some have shown that head blocks with a headboard do a better job. Others looked into using, like, you need sandbags and a headboard to get sufficient restriction. But the overall answer is that we're not really sure that these are restricting motion quite as well as we thought they might have been. And especially they also have a little footnote here about alpine sports. If you find somebody with a potential spinal injury with a helmet on, usually best just to leave it on, because you can end up inducing a lot of motion if you're trying to take that off. And when your goal is spinal motion restriction, that is not ideal. So the rigid cervical collars also, apparently nobody knows how to apply them. In one study, about 90% of providers made an error in placing one of these collars. And the provider's confidence in knowing, in their confidence in how well they felt they could place the collar had no regard on how well they could actually place the collar. So that is something of note too. So we've been putting cervical collars on a lot of people for a long time and might not have been doing it the right way for a while. And all of those questions aside, whether or not they work, there's some serious concern for the complications associated with putting a cervical collar on somebody. Talked a little bit about, when you decide that you need complete immobilization or you need spinal motion restriction, you can end up having a more difficult time getting somebody out of the wilderness. But in addition to that, there are things like aspiration or having a difficult time establishing an airway if a patient crumps on you. You can compromise respiration, particularly in elderly patients. The cervical collar can force them in positions that make it harder for them to breathe. They've actually seen increased intracranial pressure, pressure ulcers, venous congestion in the brain. So you put a cervical collar on somebody and all of a sudden your internal jugular vein doesn't want to have all the blood flow out anymore. You go as far as strangulation and concealment of developing traumas or injuries underneath. So the panel is currently unaware of any studies that showed a neurologic deterioration secondary to inadequate out-of-hospital immobilization. But you have seen deterioration and even death in patients who have used a cervical collar, particularly in patients with ankylosing spondylitis. This was a pretty big asterisk for them, was this bony vertebral bridging actually makes the cervical collar quite contraindicated in these patients, as opposed to maybe it works, maybe it doesn't. If you have somebody with a known medical history of ankylosing spondylitis, it is not the person to be reaching for a cervical collar on. So the too long didn't read is that these rigid cervical collars show a lot of risks, and we haven't really demonstrated too many benefits for them. So the recommendation, cervical collars, whether they be commercial or improvised, should be considered a tool for reducing spine motion if that is your desired goal, but it should not be used if the collar impedes emergent patient care, and there is no requisite role for these choirs in wilderness trauma care. And then also our footnote about ankylosing spondylitis, it is contraindicated to put a seat collar on these patients. Next question addressed was about backboards. They have been seeing a lot more of this vacuum immobilization technique. It is currently the recommendation of the Commission for Mountain Emergency Medicine that these vacuum mattress devices do a better job of providing you your goal of spinal motion restriction without the same issue of patient discomfort, without the same issue of potentially putting them on wrong or covering up developing injuries in the neck. So it is currently the preferred method over a backboard or a cervical collar for motion restriction. And backboards and similar devices can be used for temporary patient movement restriction if needed, but they should not be applied as a medical tool with the goal of immobilization. A little bit more on deciding exactly when to immobilize a cervical spine. There was a metadata analysis on asymptomatic cervical spine blunt trauma patients, and the result of that meta-analysis is that alert asymptomatic patients without a distracting injury or a neurodeficit who can complete a range of motion exam can safely avoid C-spine immobilization or even imaging, and this negative predictive value is at 100%. So this is these are good tools we have. We have a couple different scales. We have one called the Nexus criteria. It involves the 5 questions listed here on the slide. Does the patient have any cervical midline tenderness? Are there any focal neurodeficits? Do they have normal alertness? Are they not intoxicated? And is there no distracting injury? If the answer to all these questions is no, then you are going to have a pretty safe bet that that patient does not have a cervical spine injury. Some of the specific numbers provided here on the slide. And even in the cases where this particular method, this nexus criteria, doesn't catch every single one of the 15 missed patients in one study using EMS data, they found that 13 of those patients had stable injuries that would not have necessitated spinal immobilization to avoid future neurologic deficits. So that was one of the ways that you can use in the wilderness to decide if somebody needs to have their cervical spine immobilized. Another one they used is something called the Canadian C-spine protocol, or the C-spine rule. It's based on 3 questions. 1, do they have risk factors? Those risk factors being older than 65 years of age, a dangerous mechanism of injury, or paresthesias in their extremities, of any feelings of numbness or tingling. So if the answer to that is no, you move on to your next question, which is the injury low enough risk to assess for a range of motion? And they provide some examples here. So something like a rear end fender bender, if the patient has been able to like walk around since the injury, if they are sitting up in your ED looking at you asking, do I have a cervical spine injury? Or delayed onset of neck pain or absence of midline C-spine tenderness. Then if the answer to that question is yes, then you move on to the next box, which is the patient able to bend the neck 45 degrees to the left and 45 degrees to the right? And if you reach the end of all of that, you are unlikely to have a spinal cord injury. And once again, this is a incredibly sensitive test. It's found to be a little bit more sensitive than the nexus criteria, but they are both exquisitely good at providing a very high negative predictive value. So really good at ruling these injuries out. So these are, the recommendation turns into, if you've decided that spinal cord protection is desired, appropriately trained personnel using either the Nexus or the Canadian C-spine rule can safely and effectively make decisions in the pre-hospital setting about motion reduction. And if spinal cord protection is desired, a vacuum splint preferable to a rigid collar. Talked about that a little bit earlier. So this isn't the most explicit rule recommendation here. It provides a little bit of interpretation and clinical judgment, but these are just tools. The C-spine rule and the nexus criteria are ways that you can begin to think about whether or not you think that a patient needs to have their spine immobilized, or pardon me, not immobilized, if the patient needs their spine to be put under spinal motion restriction. So I believe we're nearing close to the end here, but one of the last recommendations they talked about was this issue of penetrating trauma. And spinal penetrating trauma is actually pretty rare, but not uncommon following gunshot wounds. So something that we do worry about here. And the neurodeficit tends to be present and final when these patients walk through the door or when you find them. You don't tend to have a penetrating trauma that ends up getting worse or develops a worse neurodeficit in your patient. So rarely do you see civilian gunshot wounds causing spinal instability, given that they tend to be low velocity compared to military gunshot wounds. But they actually recommend that routine spinal imaging is not warranted in patients without clinical symptoms. So if somebody comes in with a knife in their back and they're walking and there's no neurodeficit, it's not actually indicated to get dedicated spinal imaging. As mentioned, this high velocity injury can be more likely to cause an injury, but a lot of times it's more likely to cause a vascular injury or an airway compromise, which then you can end up with spinal injury from hypoxia and ischemia to these tissues. And immobilization actually usually makes these things worse for some of the reasons we just discussed. And mortality in one study showed that mortality was twice as high in penetrating trauma patients who had their spine immobilized. So this alphabet soup of organizations have all published statements recommending that you do not immobilize the spine, and it should not be used routinely for adults with penetrating trauma. So your recommendation ends up being spinal immobilization should not be performed for isolated penetrating trauma. If you have somebody with a neurodeficit with penetrating trauma, that is a different story. So that takes us to the discussion. Largely, we're still waiting on clinical trials. There's a lot of lack of evidence and a lack of literature behind some of these thoughts of spinal immobilization. The authors bring up that it's probably an area of immense financial harm and harm to patients and rescuers as well, given the amount of resources that can be put into removing a patient from a wilderness area with the goal of complete spinal immobilization. And it's important to keep in mind that your goal in the wilderness is not to definitively rule out a spinal injury. You're a little bit more worried about making sure you minimize the risk of exacerbating such an injury. And this is where the nexus and the Canadian C-spine rules can be your friends, but they can also be probably overly restrictive for the wilderness setting, though they can start to provide a context for your clinical thinking about these things. The authors are excited about the increasing use of vacuum splints for reasons mentioned before: better patient comfort, superior motion restriction, lower likelihood of complications. After review of the literature, authors have decided that there is not a role for rigid backboard or rigid cervical collars in the wilderness environment. If you don't have a rigid backboard and you need to get them out some other way, there's no reason to wait for one. And you're more likely to cause more harm than good putting a cervical collar on somebody. And they do mention that there can't be a reasonable set of guidelines that can evaluate each context of every potential spinal cord injury. Some elderly patients with minimal trauma will come in and have an unstable spine. Other younger people might have the most dramatic trauma you can think of, and all they need from you is to tell them not to move their neck in ways that hurt. One thing, though counterintuitive, in patients suspected of a serious spinal injury, it's actually probably even more important in those patients to avoid the immobilization. If you have a patient who's less alert, can't talk to you, can't protect their airway as well, you cause delays in care and you can end up with negative outcomes. Patients with a neurodeficit also should have these spinal cord protection principles implemented while avoiding total immobilization. So this is where you're going to reach for your vacuum splint, think about the trap squeeze maneuver, light to moderate traction, and also better to use the lift and slide method as opposed to log rolling when getting these patients onto something to get them out. Previous guidelines talked a lot about algorithms for range of motion, using that as a tool to decide whether or not somebody has had a spinal cord injury in the wilderness. Asking patients to flex or extend the neck without deficits actually used to be used as a gold standard for clearing a C-spine from radiographs before we could do spinal MRIs. But to the author's knowledge, no adverse patient reaction has ever come from trying these methods, and an alert patient will have the capacity not to cause themselves further neuro harm from being asked to flex and extend their neck. But pain alone should not disqualify a patient from attempting this maneuver, and it may prove useful for helping to decide if spinal motion is actually the desired goal. But the authors did not spend as much time in this set of recommendations talking about these algorithms for range of motion testing. And they bring up the fact that deciding on spinal motion restriction can be accomplished by practitioners with a working knowledge of the mechanisms, clinical signs of the patients, distracting injuries, which now, after this presentation, you have all the knowledge of the mechanisms and the current recommendations. And essentially, they were saying to go with your gut, and what feels right for the patient a lot of times will be right. Some of the conclusions and takeaways: immobilizing the spine is not recommended in the wilderness medicine environment. Think about spinal motion restriction. Think about being goal-oriented rather than mechanism-oriented. If you know you want spinal motion restriction, take steps to make that happen, whether those be the vacuum splints, your your trap squeeze traction, whatever you need to do. Leave your C-collar at home, pack the vacuum splint. Penetrating trauma alone is not an indication for spinal protection, and more research is needed to solidify a lot of these guidelines, but this is what we have at the moment. And that is what we have. And if there's any questions, I'd be happy to take them.
Any questions from Michael? I would recommend that video he showed of the lift to follow body mechanic and ergonomics, because that looked like it was going to hurt their own backs just from so don't follow the bending at the waist method that they were doing, but otherwise the lift is fantastic. I was just lifted like that a couple times a couple weeks ago, and I felt very safe, steady. I've been log rolled a million times in training exercises, and that's great. It's a fantastic way with a log roll to assess the back, to check for bleeding, to check for injuries, deformities, pain. One reason the log roll would be somewhat inferior than the lift, he's mentioned like the video camera study and all that kind of stuff, but can anybody think of a reason you would want to use the log roll as opposed to the lift, or the lift as opposed to the log roll?
I think airway may be a consideration.
Mm-hmm. One thing I was noticing when we were doing our rock skill session at the DIM a couple weeks back was when you're using the types of litters you use in a rescue environment, it's got walls like circumferentially around it. So if you're log rolling somebody trying to get them into that, it's going to be pretty tough, because you've got to get that stretcher underneath of them, and then you'd have to flop it up if you're just doing a log roll. So lifting directly up and then pulling the litter underneath of them, letting them down on top of it was fantastic. I mean, in AWLS and WFA, we have been teaching the log roll forever. I think I'm going to make sure we start implementing the lift. But the log roll is great for assessment. And if you're putting them on the backboard, I guess it makes sense. In the hospital, good luck doing the lift. Ergonomically, it just doesn't make sense. Body mechanic wise, you're already at a certain elevation. You're not going to go up higher. Log rolls in hospital, essentially.
And you know, also thinking about the log roll, you might be able to get away with doing it with a little less manpower, especially if you have a larger patient. It might take a few more of you to actually pick them up. So could be one time where you might get strong armed into using the log roll, but the lift certainly has the data.
You can log roll someone with one rescuer only, put their arm under their ear, roll them, assess them. No way you're lifting them by yourself, right?
Right.
Yeah. I agree with in hospital, once they're up on a ER stretcher, there's no way you're going to do anything but log roll them.
Hi, I got a comment with that for that, and actually Sully, very good job on the review. Definitely when looking at the log roll and looking at the lift and shift or lift and slide method, it's been my experience of looking at those two. You really need people that know how to do the lift and shift for the exact reasons you talked about. And so from a sports medicine standpoint, I'll tell you, if I'm doing a university game with my team around me, we'll do lift and shift all the time. We'll take off helmets, we'll take off shoulder pads, the whole bit. But if I'm at a high school game, I'm usually doing a log roll because I have less people, and the people I have usually don't know what they're doing. So having a little bit of experience on how to do that. There's lots of different ways to do that lift and shift. Most of the time you kind of put your hands kind of across each other underneath the patient and sort of lift in a genuflect with one knee on the ground and one foot on the ground, trying to keep your back steady. But actually a really cool way that the English guys do it, which makes sense when you think about it. They do a rugby scrum, right? They kind of lean in, the guy across from you leans in, and they kind of put their heads next to each other, and then they lift with their arms, and everybody's back is there and the same. I will tell you that the couple of times I've done that, I've pushed the person in front of me over, and it's been horrible. And two, you really want to be and be good friends with the people that you do that with, because you're smelling people in ways you don't want to smell people most of the time. So I'm not a big fan of the rugby scrum method, but it does work when you have people that have practiced it and done it right.
And I think most people here are students, residents, PAs, NPs, or at least some level in that training. Remember that when you're on clinical shifts, that you are still under the license and authority of whoever your supervisor is. So if they want you, and it's hospital policy and it's like trauma policy of the hospital to use C-collars, don't fight them. You can discuss these studies, and I'm sure they'd like to talk about it, but don't approach it in a way that leads to problems. So remember that until you're off on your own license, these are recommendations and guidelines, and remember kind of where you're practicing.
I would attest to that as well. Coming in from New Zealand, you're going to run up against some people who've been doing the same thing for 30 years, and what you'll be talking about is heresy to them. So I would just echo that. It's I'm a couple of years into practice now, and this is very different from all the teaching I've had before. And so, I mean, from a wilderness and SAR point of view, it's going to be great because it's actually a lot more sensible, and it's going to, you're going to, if you can walk someone out versus carry, it's a tenfold difference in speed. And I seriously mean that. You take something where you can skip up the trail in an hour, you'll take 2 or 3 minimum to get them out. So yeah, I'll just echo that. Just be careful with people who have got a license who you're talking to.
I was talking to a flight nurse and medic a couple weeks ago, and they frequently leave the collars like in their storage bin, and then they land on the helicopter deck at the hospital, and then they put it on because they just are tired of dealing with the trauma doc when they roll into the bay. And I see that a lot. I mean, at the end of the day, it's a team effort, so you don't need to butt heads, but we'll see how this goes, if it goes the way of the backboard soon, because these studies are not new. These studies have been started since I think the 80s and 90s. These things have been thought of, at least.
You guys bring up really good points. When we first wrote the guidelines in 2014, we really kind of started pushing the idea of not using C-collars and leaving the backboards alone. And it was almost heresy. We were kind of almost laughed out of the American Medical Society Sports Medicine Conference. But over time, I think now a lot of the EMS crews and probably your local EMS unit is probably now really hesitant and less likely to use their cervical collar, because those guidelines have now changed. Unfortunately, we're the first and we're always the last in medicine. We're always the first and last to change. So yes, I think very wise words. Don't mess with your attendings. Do what they tell you, but be sure to kind of talk about it amongst them and really kind of think about, what is it that we're trying to do via spine protection or spine immobilization. And I think most physicians will tell you, oh yeah, I have horror stories about keeping people immobilized for hours on end. And you turn in what could be a very simple visit and out of the ER into the patient's going to be here overnight because they have so much pain because of muscle contraction and spasm. It's a pain in the butt.
All right. Well, on that note, unless we have any more topic points to make for the guidelines, it's kind of time to otherwise move on to the articles. Saram or Daniel, one of you want to start it off?
Sure, I can go ahead.
All right.
Hello, everyone. Sorry. So can you share the article, Justin?
You want me to pull it up on the screen?
Yes, please.
Okay, give me a minute. Hold on. You can start talking. Give me I'll do it in the meantime.
Okay. Hello, everyone. So my name is Sriram. I'm a 4th-year medical student at the University of Colorado. and I'm presenting this article on an improvised cervical collar. So I have prepared brief notes on the article, which I'll be discussing. Just a second. So just to give you guys a brief intro about the introduction for the article. So modern medicine, modern emergency departments, they contain a dizzying array of tools and techniques to resuscitate and treat a variety of conditions as safely as possible. But usually situations in the wilderness often demand something that doesn't fit into a neat box. And we have to get pretty crafty. Improvised tools don't usually meet the standard of care that we try to meet in the emergency department. So based on the latest literature, we try to make the best use of the situation that we're placed in. So in this article, we discuss about spinal cord injuries. So spinal cord injuries in the United States, they account for up to 3% of hospital trauma admissions per year. So this article talks about an improvised method of using a regular fleece jacket to create a cervical collar for use in a traumatic patient. So instead of using the standard cervical collar that we use in our clinical practices, they use a fleece collar, and I am going to play a video at the end of the presentation. But pre-hospital providers, they often use the National Emergency X-radiography utilization study criteria. It's called Nexus criteria to determine whether a patient has midline neck tenderness, and then they make a clinical decision on whether to immobilize a patient's neck to prevent further injury. This study, the methods they used is a group of University of Utah students. They tried to compare the effectiveness of using an improvised collar using a fleece jacket versus the standard cervical collar that we use today. So they recruited totally 24 healthy volunteers between 25 and 45 years of age with no prior history of cervical spinal injuries. So the participants were made to sit upright, and then they were fitted randomly with either the fleece jacket or the cervical collar. Each participant was asked to sit in a neutral position facing forward, and a handheld goniometer was used to determine 0 degrees first, and then measurement of degrees for maximum flexion, extension, rotational movement, and lateral flexion was measured. And it was recorded 3 times, and then an average of those measurements were taken. The comfort level of using both of them individually was also recorded, with the 1 being very comfortable and 5 being very uncomfortable. And then a linear regression analysis was done to compare the cervical measurements for non-inferiority, and also the Wilcoxon signed rank test was used to evaluate comfort. So the results of the study was basically the measurement results. They showed that the statistical comparison between the collars were insignificant across all 3 cervical motions, meaning the fleece collar was in no way less inferior to the standard collar, restricting cervical movement. And the fleece collar was also found to be much more comfortable than the standard cervical collar that we use in our practices. The study builds upon the trust quotient from other similar articles in verifying and proving that fleece collars are indeed much more effective in doing the same job as the standard cervical collars. It also gives assurance to backcountry travelers, search and rescue groups, and mountain medicine providers for the use of fleece collars in cases of field emergencies. So front country EMS providers, they usually have historically placed patients on backboard with rigid cervical collar. And like Sully said, there's an overwhelming amount of evidence now that says that spinal protection practices are much more better now and more effective than complete immobilization. So for example, like the several studies in the last 10 years, they've shown that backboards pressing against a supine patient can cause skin injury and back pain by itself. It's just, it creates much more risk and also enables medical providers to order unnecessary imaging when the patient reaches the hospital. So to mitigate these risks, nowadays, WMS also recommends the use of vacuum mattresses, much more in the backcountry settings. So the latest guidelines from WMS, don't want to repeat what Sully said again, but they acknowledged, which it came out in September 2020, it acknowledged the techniques for immobilization for patients with real and potential spinal injury that has been implemented for decades, but they did acknowledge that it did not have sufficient high quality evidence supporting their use. So they took the drastic step of moving away from a technique-based recommendation to a goal-based recommendation of spinal cord protection instead of spinal cord immobilization. So the latest WMS recommendations puts the onus on the clinical practitioner who is present at the scene to recognize the degrees of major trauma, identify mechanisms of injury with potential to cause spinal injury, perform a basic physical examination of the spine and neurological system, and also basically recommend passive spinal motion restriction based on their assessment, which can include soft padding or vacuum splinting. They also advocate against the use of any special algorithm and also recommend avoiding total immobilization in patients with evidence of neurological deficit. They also agree with most of the other studies, including this one, in the fact that rigid cervical collars, there's very little evidence present for the use of rigid cervical collars and backboards, and they recommend the use of other adjunct devices like the vacuum splint and vacuum mattresses as substitutes. So the limitations of this study was basically the study was applied to a very small group of healthy volunteers without much prior injuries. The results were not generalized for the general population with real injuries. Also, 2 or more investigators applied the collars, so the fit might have changed, and that's not accounted for in the study. Fleece jackets, there's so many different brands in the market right now, but only one brand and one specific model of fleece jacket was used for the study. So the density of the fabric might have not been accounted for. The investigators were also not blinded to the results of the study. And also the measurements were taken only in the upright seated position, which can really have an effect on the study because in a lot of countries, patient is usually put in the supine position, and that was not tested at all in the study. So conclusion, the lack of access to even the most basic medical equipment in the wilderness can prove to be really challenging to clinical providers. In the event of a potential spinal injury, providers can be rest assured that fleece jacket could be easily used to make an effective cervical collar as a spinal motion restriction adjunct to restrict spinal movement. Compared to other devices currently in the market, and they can rest assured that it's as effective as the other spinal cervical collars that we use today in clinical practices. The results of this study also seems to agree with other studies to date, and that has also been reflected in WMS changing their official guidelines. But one thing for sure is the wilderness medical providers and other backcountry workers should be educated on the proper method to make the collar using the fleece jacket. I think the method was demonstrated in the journal. I have made a quick video, Justin, so let me share the video. So that was the video. I wish my webcam would work so I could show you guys how to put it on, but basically the folded part towards the neck, and it's just wrapped around, and the arms are just plugged in to inside the wrapping. Let me see if I can share my video. Just 1 second. Oh, it's working. Great. So the demonstration. So this is basically the one that I folded up. So it's basically, and it's basically you just put it in. So it's tight enough that it immobilizes your spine, but at the same time, it's not choking like the normal cervical collar. So, yeah.
Could you demonstrate your ability to rotate and side bend?
I really can't do anything.
All right.
It's tight enough. Any questions that I can answer for you guys?
I think that looks like a pretty viable way to comfortably remind a patient not to move their neck much. Again, it's not to immobilize them, but they feel this padded thing that's reminding them, oh yeah, don't do that.
Yeah.
So that's, I think, from my perspective, the goal in this. That was surprising to see how well it worked.
Pretty sure, and it's really comfortable. So I have a cervical collar at home, so I tried it on and compared it, and this is really comfortable. So.
When I was one of the patients a couple weeks ago, they didn't put a collar on me, but in the sked they put basically all their puffies, their the little collapsible bags with their extra clothes around me, and that worked great. So if you don't have a collar, you could just fill the voids in the sked or the stretcher and then strap them in, and that worked pretty well. But that vacuum splint was fantastic. Put the helmet on, take the straps around the forehead or the front of the helmet, and then take the air out of the vacuum splint, and I was comfortably unable to move. The worst thing was the helmet, because it's rocking it actually felt like it was rocking my neck back. But other than the helmet, that was great. I feel like maybe a little something under the helmet even would have kept me more protected. And that was the first time I'd ever been immobilized somewhat for at least an hour before. And as a awake, non-injured person, I just wanted to take this second to remind everybody, injured patients get cold fast, and hypothermia actually has different temperature thresholds in trauma patients than in non-injured patients. So once you bundle them up, once you protect the spine, remember, keep them bundled. All these different things kind of come into one, like hypothermia meets spinal cord protection meets musculoskeletal injuries. It's all combined. But yeah, I'd actually, if you were interested, I'd love to use your video if you would like to add the application part to our advanced wilderness life support course we teach. We have online videos that we use. If you'd be open to it, I'd put your name on there and credit you. But that was
no issues. I can send you the file afterwards.
Awesome.
So thank you.
Yeah. Any questions for him? All right. Well then, if Daniel, you're ready, I think you should be able to share screen. Take it away.
Alrighty. Hi, everyone. I will pull up the PowerPoint. Alrighty. Can someone pipe up and let me know if you can see the PowerPoint I'm trying to share?
You're all good.
Yeah, once again, I'm Dan. I am about to start as an emergency medicine intern at Brooke Army Medical Center in San Antonio. And All the views expressed are, of course, my own and don't reflect the opinions of any affiliated institutions. This article is about ski and snowboarding medicine, essentially, and I have no experience on ski patrol. So if anyone wants to add any of their insight throughout my presentation, please feel free to do so. And also, my internet sometimes is unstable. So if you guys are having issues hearing me, please let me know and I can cut the video feed and see if that helps. But without further ado, the article I'm going to be discussing is titled "Cervical Spine Alignment in Helmeted Skiers and Snowboarders with Suspected Head and Neck Injuries: Comparison of Lateral C-Spine Radiographs Before and After Helmet Removal and Implications for Ski Patrol Transport." It's quite a mouthful. So the authors make the following statement kind of as a premise for justifying this investigation. Basically, they say that current protocols for spine immobilization of the injured skier or snowboarder have not been scientifically validated. And they go on to say that no other studies address helmet removal for injured skiers or snowboarders. And their primary research question boils down to whether helmet removal with or without C-collar application results in additional C-spine manipulation among injured skiers or snowboarders. So as a background, to give some context, the rate of injury among skiers and snowboarders is about 230 per 100,000 mountain visits, greater than 10% of which are head and neck injuries. And in the 2011-2012 ski and snowboard season, there were 54 reported fatalities and 51 severe injuries, including some resulting in coma and paralysis among winter athletes. A little bit more about the authors to potentially give context regarding bias and whatnot. The lead author was a University of Minnesota Duluth medical student, so kudos to him for getting some research published. And the senior author was a sports medicine fellowship trained orthopedic surgeon and medical advisor to the Spirit Mountain Ski Patrol, which is a ski mountain in Minnesota. They did not report any funding or any disclosures, and it was located in a classroom setting during an outdoor emergency care course, which is a medical course that a lot of ski patrollers take. They didn't specifically say where geographically it was located, but kind of assuming that it took place at their ski mountain in Minnesota. Regarding the participants, they report a sample size of 28 healthy adult volunteers, 18 of whom were male, 10 female, with an average age of 47 and a range pretty broad from as young as 20 to as old as 73. And it was kind of a convenient sample. They don't give any explanation of why they selected that many. It just kind of seems like that's how many people showed up and agreed to be a part of the study. And their inclusion criteria consisted of volunteers that were current or candidate ski patrollers. And they said that they excluded anyone under the age of 18, anyone with a known pregnancy or prior history of C-spine injury or surgery. However, they don't report whether or not those criteria actually resulted in any exclusions. They just said that none of the participants had any of those criteria. For the methods, they based their study design off of a previous study conducted by Swenson et al. On helmeted football players. And they wanted to do the same sort of study on skiers and snowboarders. So that method was arranging 3 mock rescue scenarios involving C-spine stabilization of an injured skier or snowboarder. Again, it was conducted in a classroom setting, and the people who were acting as rescuers in these scenarios were ski patrol candidates. So these people in this outdoor emergency care course. So relatively inexperienced rescuers. And the 3 rescue scenarios were as follows. There was a control scenario where the mock patient or the participant was, their C-spine was immobilized with their ski helmet on and no C-collar was applied. And they said this was the control condition because they assumed that this was the condition in which the C-spine was least likely to be manipulated. And the 2 experimental conditions were when they tried immobilization well, again, leaving the helmet on, but this time applying a C-collar. And then the third condition, or the second experimental condition, was to remove the helmet and apply a C-collar and immobilize the C-spine under those conditions. So after the patient was fully immobilized, they took a lateral radiograph, which was viewed by 2 blinded observers, and then they used digital imaging software to calculate the degree of cervical extension in each of the 3 conditions, and then compare the angles. So the results they reported significantly increased cervical extension in both of the experimental conditions compared to the control, that is, removing the helmet and putting on a C-collar, or leaving the helmet on and putting on a C-collar. And so I don't know if you can see my mouse, but I also highlighted just the degrees of an extension. So that's the difference in the degree of extension between each condition compared to the control. And they measured from a couple of different anatomic landmarks, from somewhere on the bottom of the occiput to either cervical level 2 or 7. And it was statistically significant between the occiput and C7 in both the experimental conditions. And then in one of the experimental conditions, just between C2 and C7, with a p-value of 0.001 under 3 of those comparisons. And then they also reported the time that it took to remove the helmet and apply a C-collar. And they gave a range of 6 to almost 14 minutes. And then they subsequently did an age and gender subgroup analysis that showed increased cervical flexion among women participants and participants younger than the age of 50. But this effect was preserved across all conditions, and so it didn't affect when they looked at the changes in alignment. And so it's just kind of a finding that they wanted to report, that under all conditions, these subgroups demonstrated increased cervical flexion, or cervical flexion, yep, compared to everyone else. So some of the potential limitations of this study, they report that the lateral radiographs were viewed by blinded observers. However, they didn't report whether, and they could have been medical students, or they could have been, experienced radiologists. We just don't know that. And that could have influenced the measurements that they were making. And then something that I noticed, if you look at the example radiographs that they showed, is that you can see little dots right next to the skull in the 2 helmeted conditions, which I assume are just radio opaque elements of the helmet. So it's not truly blinded, in my opinion, because any observer could kind of unblind the conditions just using context clues. Another potential limitation is, like I mentioned before, the rescuers in this simulation were rather inexperienced. They were still working on becoming ski patrollers. And so helmet removal and C-collar application takes practice to do it effectively, to decrease the amount of time that it takes, and likely to decrease the amount of manipulation required to effectively apply these interventions. So it's conceivable that if you did this study with more experienced rescuers, that in some of the conditions or all of the conditions, there may be more or less manipulation. And then back to the sample size, like alluded to earlier, relatively small, but as far as wilderness medicine studies go, 28 is pretty good, but they didn't really discuss why they chose that number. They didn't provide any power calculations. And then also, we're just looking more at the statistics that they did when comparing the 2 observers, the 2 independent observations of the lateral radiographs. They reported a Cohen's kappa of 0.85, which is a strong correlation. So that's pretty good. Gives us confidence that the observers are reporting the same thing for what they're looking at. And then for the results, they had strong associations with p-values of 0.001. And then another potential limitation is that they're just reporting these angles as an end state after the patient's fully immobilized, and it doesn't capture the cumulative C-spine motion throughout the rescue. So something we would be concerned about as rescuers is how much is the C-spine being moved throughout the stabilization process and throughout the extrication. And this is basically just saying, once it's all said and done, here's what it looks like. And so they did kind of mention that it would be very difficult to capture that, but just bear in mind that we don't have that information. More discussion. Like I said, the methods they used were based off of a previous study involving football players and removing their pads and their helmets. And they basically said that their conclusions were similar to that with the football players. That kind of increases our confidence in these results, that they're replicating what's been seen in the past. And then regarding their time factor, I think I mentioned this. This wasn't a primary outcome, so to speak. They're just kind of letting us know that removing a helmet and applying a C-collar takes some time. That's variable. And like I said before, if they're more experienced, it potentially could take less time. But that's something to think about, you know, in a winter environment, spending potentially 14 minutes to stabilize the C-spine without any potential benefit of doing so. You know, you could potentially be an avalanche zone. You could have a hypothermic patient and you're spending 14 minutes to do something that could actually be harmful to the patient. So that is something to think about. In conclusion, they state that helmet removal and C-collar application leads to increased extension of the cervical spine. And in the absence of other clinical factors, our recommendation is that helmets should be left in place and C-collars not routinely applied during ski patrol rescue. And this study was conducted in 2017, which was before these most recent WMS guidelines for spinal cord protection. So they were actually cited in the guidelines in the introduction. And the most relevant component of the guidelines to this paper is basically the part that says that if no injuries or other circumstances such as unconsciousness prevent controlled self-extrication, patient's cervical spine should be packaged to reduce passive motion without the goal of absolute immobilization. There is no requisite role for rigid cervical collars in an out-of-hospital environment. So the guidelines are saying that you don't always need that rigid cervical collar and that you don't need to remove a helmet, you know, to get complete cervical immobilization. And so that's where this study results and the guidelines are kind of in unison about that. For future studies, this was all in a classroom scenario. It'd be very difficult to do anything like a randomized controlled trial, but it would be useful if it was somehow possible to collect some observational data on, for example, on injured skiers and snowboarders and see if you could observe any differences in patients that happened to be immobilized versus those that were not. And once again, if you were to repeat the same study with experienced rescuers and then see if that had any difference on the results. And before I wrap up, they did have a really useful table in this article, indications and contraindications for helmet removal. So of course, their final recommendation is to not routinely apply or not routinely remove the helmet. But here are some indications that you would want to remove the helmet. So an absolute indication for helmet removal would be if you're unable to establish an airway with the helmet on, if they have an open head wound or bleeding under the helmet, if they have a severely damaged or unstable helmet. And then some relative indications for helmet removal include an unorthodox helmet shape, or if they have something attached like a GoPro on top that's making it cumbersome or causing their head to get yanked around. And if the patient's alert and complaining that it's uncomfortable. And then some contraindications that you'd say, oh, well, I wasn't going to remove it anyway, but some reason that I would definitely not remove it would be if there's a C-spine injury with a neurologic deficit where you absolutely want to minimize the manipulation of the C-spine. And then when there's environmental factors where you want to keep their head as warm as possible, so it's super cold out, or if they're in a dangerous area where you want head protection, I wouldn't hastily remove that helmet. So that's all that I have in the discussion about this article. I welcome any comments or feedback about that.
Daniel, I thought you did a great job. Very good job covering the article. You know, for those of you that may not know me, I'm a family medicine and sports medicine physician. And I cover the University of Nevada, and I've worked in the NCAA for quite a number of years. And can tell you when it comes to whether it's the NFL or the NCAA, But when it comes to helmets, there's a lot of research done on them. And right now, if you are surrounded by a bunch of people that you've helped trained, what we'll do is kind of a crazy thing. We do the lift and shift, but you'll see us lift, or there's even like a tilt that we do, and you'll watch one guy will pull the helmet off. Someone will straddle the athlete, put his hands under the neck, and we'll pop the helmet off, and then we'll pop the shoulder pads off. And the reason that we went to that mechanism at the NCAA level is because the helmets have become much more sophisticated in their ratcheting mechanisms. Some helmets, they pop off. They have these little kind of dial things that you got to stick something in there and they pop off. Other ones are screws. Some of them actually have plastic dials that you got to turn, and then the whole helmet, like the face mask, pops off, and it's easier to get the straps off that way. And so we found, actually looking at different studies, that if we on the field, guys who actually know what equipment the players are using, removed them, there was actually less cervical motion than if we let people who, were trying to do the best they can, but had no clue what is this helmet crazy looking thing. Because there's all sorts of helmets. There's Schuts, there's Rydell's, and then even the different Rydell's have different mechanisms for removing, and it's crazy. So we've gotten away from that. But I think this article brought out really interesting. In a non-football player, what do you do? Oh, by the way, before I forget, for those of you students, and for those of you that may be residents or fellows, chances are at some point in your training, you're going to do a high school football game. When you're at the high school football game, always leave the helmet and the shoulder pads on, because they sort of match in size. When you take the helmet off and not the shoulder pads, you actually extend the neck. When you take the shoulder pads off, leave the helmet on, you actually flex the neck when they're lying down. And it brings up a good question. We've always thought that was bad. Is it really bad? I don't know. Could be bad. Could not be bad. I don't know. There's no data that tells me it's bad. It sounds bad. So we kind of decide that, yeah, we want to keep you in neutral position, right? That's always the thing. So that's why we take them all off at the same time. Plus, it's easier for us to take them off. In an austere environment, because we use helmets for everything, right? I mean, this article is about snow, but I mean, hell, I got a garage full of helmets. We got a helmet for everything. I got a helmet for cycling, for snowshoeing, for rock climbing, for alpine climbing, right? I mean, you got tons of helmets now, and all of them attach and detach differently, made of different substances. Some of them have the MIP system. Some of them don't have a MIP system. And what the hell is a MIP system anyway? Some of them use a Bose ratchet. Some of them don't use a Bose ratchet. All sorts of crazy stuff out there. But removal of the helmets, if you don't know how to remove the helmet, oftentimes, or if you're not familiar with that helmet, there probably isn't a really big reason to remove it. It's going to get taken off in the ER by people that actually, where there's more people, there's more light and more ability probably to do it safely. But if you're in an environment where you've practiced it, it might be something to look at. It's definitely something I know that in the next version of the spine guidelines, we've already started talking about. So kind of interesting. So I thought it was a great article. I think for right now, definitely don't remove a helmet, especially if you're at a high school football game on a Friday night and you have like another student with you and the attending. Don't remove a helmet. Don't remove the shoulder pads. Just transfer them as it is. If you're on the side of a mountain and one of your buddies falls and kind of loses some consciousness for a while, and you think you need to transport them, you call the authorities, they come in there, leave the helmet on. Easiest way to do it. But these are great questions.
Yeah, I actually just redid an ATLS, I guess about a month ago now. And that was the first time that I had seen in a structured national training organization teach how to take a motorcycle helmet off. So I'd never personally seen it done in the ER. So I'm sure glad I did in a training scenario, but there are definite steps to it. And if you don't know how to do it in like an airway emergency, in a severe hemorrhage situation, I can see how you would probably be a bit nervous in that situation and might potentially rush. So kind of a good thought, I suppose, to look into how to actually do it as well when indicated.
Yeah, these are all really great points. And they did actually show a picture of, I guess, their recommended way to remove a helmet. But I guess that just adds more to the experience of the rescuers is important. If someone's never seen a ski helmet before, never removed one, there could be a lot of jostling if they don't know what they're doing.
Yeah, I'm actually a ski patroller, and I'm also an emergency medicine resident. So I was thinking about, like, this helmet has got to come off eventually anyway. I was thinking about who would I rather have take my helmet off if I was in this position. And I gotta say, I think I would rather have ski patrol take my helmet off. Because, and especially, like, maybe not so much helmets, but definitely like ski boots and snowboard boots. I don't know if you guys have ever tried to take them off your friends. If you're not familiar with those contraptions, sometimes it can be very challenging to get those things off. And if they have an ankle injury or something underneath and they're screaming at you, it's easy to get flustered. And so we kind of half jokingly say, like, when we're patrolling, like, we're going to take this boot off for you right now because, trust me, you're going to want us to take it off and not in the emergency room. So I don't know, I kind of wish they had, like, taken it a step further. It would be interesting to see, like, if they compared it to healthcare providers or, like, in the emergency room, like what the flexion extension difference would be there.
I think it's a great point, Dr. Dinello. Excellent point. And that actually gives legitimacy to something that I've done for years, which drives people crazy. Because every time I go into REI, I go in over to the helmet section or the boot section. Oh, and ski boots, mountaineering boots. Oh man, trying to get those off on a frozen foot, forget it. Right? It's very difficult to do without, like, pulling some tissue off as well. But I go into REI and I start messing with everything. I start pulling boxes out, and they hate it when I do it. But actually, it helps quite a bit. It's how you kind of learn about the new stuff out there, the new lashing systems or the new concussion, quote unquote, systems that are out there. I think it's a great. That's why we do the football helmet removal, because I know that if I send this kid to the ER, they don't know how to take the football helmet off, right? They're going to end up pulling out the angels and cutting through the plastic areas and trying to rip it off, when there may be other ways quicker and more efficient in getting the helmet off. Yeah.
Well, before everybody logs off, which I've seen people do, I'm going to stop recording unless anybody has any questions for the actual topic. Any other further questions or points you want to make? Okay, recording stopped.